Well, thank you so much, Erin. I'm honored to be here today speaking about a portion of my doctoral work in Professor Ellen Roach's group at MIT. But before I jump into the science, I'd like to tell you about what motivates me to be here today. I am the product of people that believe in enabling those who come after them to achieve great things. And it is because of those who came before me that I've received the necessary training to become both a biomedical engineer and a professional dancer. And by living at the interface of these different disciplines, I know I'm capable of collaborating, finding unexpected connections, and leading creatively and with empathy to enable those who come after me to keep doing the same. I dream of a world where education in science, technology, engineering, and the arts enables individuals like me to grow into who they want to be and contribute to the advancement of society. I also dream of a world where lack of knowledge about a patient's disease is not the reason why some patients receive suboptimal clinical treatments, especially if they belong to an understudied group. I'm here today because with an academic career, I can bring these foundations together, contribute to building the reality I dream of. And I'll start by zooming into the research I've done and will be the basis for my future research program, which I envision will focus on developing platforms that modulate mechanics and biology to elucidate disease mechanisms to help give better treatments to diverse patient populations. Thus far, my work has focused on improving and developing implantable devices for the heart after a heart attack. And during the first part of my PhD, I optimized a cardiac reservoir system to study dosing of a regenerative protein. And the second part of my PhD, which is the one I'll talk about today, I developed an adhesive patch that can be used to study how to best reinforce the region of the heart that gets damaged by a heart attack. I'll start by telling you about the clinical motivation behind this work. As many of you know, for the heart to pump blood efficiently and meet our body's oxygen demand, all cardiac muscle cells in the heart need to contract and relax in a coordinated manner. And during a heart attack, this is disrupted because a coronary artery gets occluded and interrupts blood flow to a region of the heart. This damaged or infarct region loses its ability to contract, which subjects the surrounding healthy muscle to abnormal strains and decreases the heart's pumping capacity, forcing the unaffected muscle to dilate and remodel to pick up the slack. Remodeling is pathological, self-promotes, and can end up preventing the heart from pumping enough blood to meet the body's demands, a condition that we call heart failure. Although nowadays most heart attack patients receive interventions that revascularize or reopen the blocked arteries to limit damage, about 30% of them end up developing heart failure within 5 years after their first heart attack. And once heart failure develops, these patients have very limited options. Their symptoms are typically managed through medication and lifestyle changes. And if heart failure is severe, assist devices can be implanted to act as a bridge to transplant or destination. I was able to see firsthand the immense burden that heart failure has in these patients during the 8 weeks that I worked in a hospital as part of my PhD program. And I have to say, it's truly a fight between slowing down disease progression and maintaining quality of life. Yet, there's still no clinical options that focus on recovering the lost cardiac function to prevent pathological remodeling and progression to heart failure altogether, representing an essential unmet clinical need. And one approach scientists are testing to address this clinical need involves coupling acellular patches or biomaterials directly onto the surface of the heart early after a heart attack. And by implanting these patches, we mechanically reinforce the infarct region, which prevents dilation and can also reduce the abnormal motion induced by the infarct. So you can think of these patches pretty much as a brace for the heart because they're placed to prevent undesired movement of the region and avoid further damage. And also, like a brace, the level of reinforcement a patch provides depends on the patch material properties and under how much tension the patch is attached to the heart. So what variety of patch materials have been evaluated in animal models so far? And these range from stiff textiles to soft hydrogels, which have very different mechanical behaviors and elicit different host responses. However, despite all these differences, all these studies demonstrate some improvement of cardiac function and reduced remodeling weeks after a heart attack, which would make you think that that's a good thing, right? And the answer is that not really, because with all the variability, we cannot really pinpoint what patch design parameters are important for correcting biomechanics or preventing remodeling, which limits how much more we can improve this potential heart failure prevention strategy. And as an engineer, I thought we could do better and started deriving the design requirements to develop a material platform that can help us elucidate this connection. The platform needs to be easily attached to an animal's beating heart to ensure a consistent level of reinforcement. We need to be able to program a wide range of mechanical properties to the patch that ideally include those of previously tested patches without changing the formulation or chemistry of the material so that the biological response to the patch is comparable regardless of the mechanical properties. The size and shape of this patch should be customizable so that it can be used in different animal models. And finally, the patch should change how heart muscle motion or biomechanics of an implantation, which surprisingly is a validation step that is often overlooked in previous clinic studies. To achieve this, I joined efforts with Dr. Hyunwoo Yuk from the Zhao group at MIT, who's an expert in soft materials and 3D printing. And we developed a patch platform that met this requirement. Patches have components. First is a bioadhesive hydrogel that allows for easy coupling to the heart without the need for sutures. Now, this may sound trivial, but achieving fast and robust adhesion to a wet and dynamic organ is actually quite difficult. And this is why I first worked with Hyunwoo to optimize the in vivo performance of a hydrogel that adhered to the heart after applying 5 seconds of pressure. In the third image here, you can see that the hydrogel resists pulling shortly after attachment. And the fourth image actually shows that the adhesion remained for a few days. Now, the second component of our patch platform is the sinusoidal fiber mesh that determines the mechanical behavior of the patch and is made by 3D printing so that the size, shape, and fibers of the patch are customizable. In fact, it is by changing the parameters like fiber density or fiber morphology that we can get patches with very different mechanical behaviors without changing how the patch is biologically perceived by the heart. For example, in this stress-based strain plot generated by Diego, an undergrad now PhD student that I mentored, shows the patch mechanical properties we can generate simply by changing the fiber amplitude. We can fabricate a stiff patch by printing patches with 0 amplitude as indicated by that steep slope. And we can also fabricate soft patches by printing fibers with higher amplitude as indicated by that shallow slope. And now finally, I'm going to tell you how I validated that our patches indeed have a direct impact on the motion of the heart. So what I did was I used ultrasound to record a video of heart motion of rats that I had induced heart attacks to. I then placed these yellow speckles on the infarcted muscle and tracked them during 1 heartbeat to quantify the longitudinal strain of the region. Next, I attached a patch with straight fibers, which was programmed to limit that longitudinal strain, and tracked how the motion of the speckle changed after patch implantation. So here you can see how one of these ultrasound videos typically look like. These are the speckles there in colors and tied by a green line. See how they move as the heart contracts and relaxes. And then the white bright region on top is the patch that I implanted. Now, going to the data, in this blue graph, I'm showing you the mean longitudinal strain and standard deviation quantified from the moving speckles over time in 1 heartbeat before the patch was placed. And you can see that very wide distribution. And that is actually characteristic of the abnormal motion and increased deformation of the infarcted. Now in this red graph, I'm showing you the same metric, but after the patch was placed. And you can appreciate how the variance in strain decreased upon patch placement, meaning that the patch reduced how much certain speckles in the region were moving, as it was intended by the implanted patch design. Now, this is from a representative animal, but when we look at the data from the whole group, we see that this holds, confirming that the patch is modifying the biomechanics of the region upon implantation. In the future, I want to include other patch designs and animal models into this characterization and extend it to a chronic model to see how different acute biomechanical changes translate to remodeling and heart failure prevention. Now, as I mentioned before, I want to continue using devices and platforms that modulate biomechanics to probe understudied disease mechanisms. To be better equipped to do that, I recently started a postdoc in Professor Christopher Chen's lab at Boston University, where I'll be learning to evaluate the biological impact the biological impact of diseases and mechanical interventions using human-derived cell culture models, which also will allow me to incorporate variables exclusive to the human species. Finally, I'll zoom back out from the research training that I've received in preparation for my academic career, and I want to briefly highlight the mentoring, advocacy, and interdisciplinary educational initiatives that I've been a part of and be fortunate to collaborate with, because these have given me the equivalent training I'll be using to advance the other foundational components of my career as a professor. And with that, I want to thank everyone involved in the research I discussed today and my funding sources. Thank you so much for having me, and feel free to reach out with any questions.